on Monday. The medial 2/3 is convex, lateral 1/3 is concave. The medial 2/3 has a rounded contour, lateral 1/3 a flattened contour, where it goes from convex to concave, round to flat. The junction of the middle third and the lateral third, right about here, produces an anatomical weakness in the bone, common site of fracture in motor vehicle accidents, seatbelt. Okay, so we're going to palpate his clavicle, and so he's got a good one. You can definitely see that's concave, bowing out, and that's concave. That's convex, bowing out, concave, bowing back. So I'm going to start at the medial end and just palpate along the clavicle. So if I get in here and he starts to say, ouch, I'm possibly thinking he has a fractured clavicle. Okay? So then I come all the way out to the lateral end. So there's the lateral end of the clavicle. So it's well defined. I drop off that. I'm now on the acromion of the scapula. So here's the acromion, right there. I drop it off, acromion. Then if I track the acromion posteriorly, it's renamed scapular spine. So you can turn around. So acromion, and then I find the scapular spine, come all the way over to the vertebral border. So if you put your hand in the small of your back and relax, that's the vertebral border, closest to the vertebral column. If I track all the way down, that's the inferior angle. If he says, ouch, it hurts there, I'm thinking, what attaches there? Teres major. I track all the way up to the top, I get the superior angle. If he says, ouch there, what attaches there? Levator scapula. If he has pain along the vertebral border, I'm thinking the rhomboids, minor and major. And deeper would be serratus anterior. Okay? So I find the scapular spine and go above. That's the supraspinous fossa. So right here, the scapular spine above supraspinous fossa. Below, in here, that's the infraspinous fossa. Okay? If he has pain there, that's the origin of infraspinatus. If he has pain in the supraspinous fossa, I'm actually palpating trapezius, right? But if he says deep pain, I'm thinking possibly supraspinatus, underneath the trapezius. Okay, then if you find the inferior angle and come up along this lateral border, which is called the axillary border, closest to the axilla, there's pain in there, that's the insertion origin of teres minor. Then the last thing, turn around, please, the coracoid process. The coracoid process is this bony projection coming off the front, slightly inferior to the clavicle, slightly medial to the humeral head. So it's in this little depression right there. So if he has pain right there on that bump, 3 different muscles attached there. Pectoralis minor, coracobrachialis, short head of the biceps brachii. So lots of things attached to the coracoid process. That brings us to the humerus. So you put him in the anatomical position. I can palpate the entire shaft of the humerus. Where the deltoid comes to a point, that's the deltoid tuberosity. It's not a real bony prominence like most people's tibial tuberosities, but it's right there. Then I'm going to palpate the bicipital groove, the lesser tubercle, and the greater tubercle. So right there. Now you can't really palpate that directly because the deltoid muscle is too big, but relax your arm just a little bit, and I'm going to just tighten your bicep a little bit. I can split his 2 heads of the biceps. See that? And again, that doesn't hurt, right?
No.
That's the short head going over to the coracoid. This is the long head going right up through the bicipital groove. So you really can't feel it, but it's there. So medial is the lesser tubercle. If he complains of pain there, I'm thinking, what attaches there? Subscapularis. If he has pain on the greater tubercle, that's the sit muscles, SIT, supraspinatus, infraspinatus, teres minor. Everybody good? Okay, so you have to palpate all those things. So muscles. First, pectoralis major. Pectoralis major is a very important muscle in lots of things we do in sports and athletics. But it has 2 different functions completely, 2 different parts. The clavicular part attaches to the anterior surface, medial one half of the clavicle. From there, it comes over to the lateral lip of the bicipital groove. So if you know the origin of a muscle and you know the insertion of a muscle, you should be able to figure out the action when it contracts concentrically. So if it's going like this, it's going like that. When it contracts, the arm's going to come up. So it's a shoulder flexor. So I'm going to push your arm down, don't let me. And there it is, right there. Sternocostal part is not working right now. Okay, so relax. Sternocostal comes from the sternum and the costal cartilages of the seven true ribs. So the upper fibers come straight across, but most of them come up like that. So when the muscle contracts like that, it brings the arm down. So clavicle part brings it up, sternocostal brings it down. So push down on my shoulder. So now it's working. Clavicular part is not working. Now both parts of the muscle working together, it's a powerful shoulder adductor, horizontal adductor. Just as many people call that horizontal flexion. So just kind of push me like that. Whoa, I know you're gonna be that strong. So push me that way. So now they're all working together. So people, when you had anatomy, did the professor show you that in class? Doesn't it make a whole lot more sense? Well, you see it, okay? So on the lab exam, all you have to do is say pectoralis major. And you don't have to do all that other stuff. Deltoid, right? Anterior fibers, middle fibers, posterior fibers. All fibers working together, powerful abductor. Anterior deltoid is a flexor and horizontal adductor. Just as many people call that horizontal flexion, okay? Posterior fibers are extensors and horizontal abductors. Just as many people call that horizontal extension. Okay, you just have to say deltoid. And trapezius, most people say this is your trapezius muscle, but it goes all the way up to this bump on the back of your skull. The external occipital protuberance comes all the way down to T12. The upper fibers come down attached to the posterior lateral 1/3 of the clavicle. The middle fibers come across attached to the scapular spine. The inferior fibers come up and attach to the base of the scapular spine. So people, when you take cadaver anatomy, that's the first thing you're gonna dissect. Your cadaver is gonna be prone, and you're gonna skin the person and see that superficial layer of muscles. Trapezius up, latissimus dorsi down below. So then, supraspinatus. You can't feel this directly. So, but I find the scapular spine and I go above into the supraspinous fossa. If he says deep pain, I'm thinking supraspinatus. Find the scapular spine and go below. That's the infraspinatus muscle coming over to the greater tubercle. Find the inferior angle, come up along this axillary border. That's teres minor. So if he brings his arm out to the side and push down on me, that's teres major right there. I go above teres major, that's teres minor. So in the lab exam, people, that's what I want you to do. Triceps in the back, biceps in the front. Okay, we're almost done. Ligaments, sternoclavicular ligament. So if the injury you draw says sternoclavicular ligament, that's your injury. When you palpate that, he's going to say ouch. When you do the stress tests for that joint, depression and compression, he's going to say ouch. Come up to the AC joint. If he has pain there, you're thinking AC sprain. When you do the tests for that joint, they're going to be positive. The third ligament is coracoclavicular. Goes from the coracoid process to the undersurface of the clavicle. So it's right in there. So you find the coracoid process. So the coracoclavicular ligament is right there. Actually, two ligaments, trapezoid and conoid, which we'll review when we talk about the shoulder. Then you have the glenohumeral capsule. Anterior capsule, posterior capsule. If he has pain on the anterior capsule, I'm thinking he subluxed possibly his glenohumeral joint. Classic mechanism, is football arm tackling. Instead of tackling with the shoulder, chest, the ball carrier makes a move. He reaches out to grab the guy, and his arm goes back, and he sublux at the front. If it's pain on the posterior capsule, he's an offensive lineman blocking. Somebody hits him there, force goes on the long axis, drives the humeral head out the back. Thank you. Good model.